started with our excellent presenter, Dr. Rachel Soslin. She's going to talk about all things urology for women. And she was here a couple weeks ago and talking about men, and people really loved it. She's going to tell you all about herself, except that she's not going to talk about the fact that she moved 11 times before she was 12 as a military kid. Anyway, so here she is, and she'll tell you all about herself and everything. Bye-bye.
Can y'all hear me okay?
Yep.
Okay, great. Okay, thank you, Kathy. Thank you, Debbie, and the Wellness Committee for having me and having me back. As I mentioned, I was here about 2 weeks ago and gave a presentation on men's health topics. And I love men and I love taking care of men, but I'm a woman. And so this is particularly near and dear to my heart because I am now an 8-month pregnant woman, and for the second time. And so a lot of these issues that you all have, I have too. And so it's important, it's really, really important to me to raise awareness about issues that many people don't talk about. Physicians are notoriously bad about asking about these problems, okay? So we're gonna be talking about leakage, recurrent urinary tract infections, things hanging out, the bladder falling, all sorts of things that nobody likes to talk about and nobody likes to think about, and I'm gonna try to make you comfortable asking about those things. And if your doctor doesn't want to talk about those things, I want to talk about those things. So come see me, come see my partners, we can get you fixed up. And I want you to have confidence that you do not have to live like that. So I'm going to talk to you about what you need to know that no one tells you. Let me make sure I have my clicker. Well, I'm going to use the mouse, but thank you so much. We'll check on the battery for that guy. Okay. So first things first, I'm going to tell you a little bit about me. Thank you. So I grew up in Fredericksburg, Texas, just down the road. As Kathy mentioned, I was a military brat, so I moved around a bunch beforehand. And then got my finance degree at UT here in Austin, moved on to what's now UT Health in San Antonio for medical school, went to Vanderbilt for residency, and like I said, I treated a lot of men in residency and didn't feel as comfortable treating women when I left 5 years of surgical training at Vanderbilt. So I went on to do a fellowship in female pelvic medicine and reproductive health and reconstructive urology, thank you so much, at Houston Methodist. And then, 4 years ago, took my first job here at Urology Austin. So I've been here for 4 years. Cindy is not here with me today. She was here last time. She is a doctor of nurse practitioner. And I want you to remember her face. She is wonderful, she's empathetic, she is incredibly knowledgeable. We have trained together, she knows everything I know. And when I'm out on maternity leave pretty soon, if you guys want to come see someone, she is a great person to see that can get you into our practice so that we can get you some help. I'm located at 608 Radham Lane. That is down on South 1st and 290, right by that St. David, South Austin. It's about a 10-minute drive from here. But we have 18 different locations in Urology Austin, and I have other providers and partners who take excellent care of men and women. So if that's too far for you to drive or that seems like not your area of town, we have other places, including a new office that's opening up just north on Mopac at the end of October. So we have a brand new location there. Okay, so our agenda for today. I want to talk about 4 things: urinary tract infections, something called genitourinary syndrome of menopause. So what happens to us after we go through menopause and how that affects us from a urology standpoint, leakage, and prolapse. Prolapse is when people talk about their bladder falling or something falling. That's prolapse. Okay, so here we go. Urinary tract infections. I bet everyone in this room has had a urinary tract infection or knows someone who has had a urinary tract infection. 60% of women will be diagnosed with a symptomatic urinary tract infection at some point in their lifetime. Up to 50% of women will have multiple urinary tract infections. And while some people may have them infrequently, if you have more than 2 in 6 months or 3 in a year, we consider that recurrent infections. You're getting too many. There's something going on. You should not be getting that many infections. They're costly, they're time-consuming, they're preventable, and most importantly, is they can lead to other things. They lead to hospital admissions, they lead to falls, they can lead to death. If you get sepsis, you may have heard about bacteria in the bloodstream. So these can be very dangerous, and they're really important. It's important for you to know they can be prevented. So what is a urinary tract infection? And this part is super important. The next couple slides are probably things that no one has told you. So a urinary tract infection requires 2 things: bacteria in the urine and symptoms of a urinary tract infection. So classic symptoms are burning with urination, urgency, frequency, pain in your bladder area, blood in the urine. Those are classic symptoms of a urinary tract infection. But I have many patients that have those symptoms that don't have bacteria in their urine. And those are different problems that I can fix, but they're different. You have to have bacteria in your urine and those symptoms to have a urinary tract infection. The other side of that coin is that many women have bacteria in their urine that just lives there. Like bacteria lives on our skin, or lives in our mouth, or in our nose. It's called colonization. It just hangs out there. Doesn't cause a problem at all. So many people come to my office after having been on antibiotic, after antibiotic, after antibiotic, and they don't have symptoms. That's not a urinary tract infection. And all we're doing by giving you antibiotics is making those bugs not work against antibiotics, causing diarrhea, causing yeast infections, causing other problems. So I don't expect any of you to always know what's going on, but we as doctors should know, and we should be doing the right thing. So I'm going to explain what happens when you come to the office and you give us a urine, okay? You come to the office, we say, can you please give me a urine sample? You go to the restroom, you try to give us a urine sample in a tiny little cup. Inevitably, it's going to hit the labia, it's going to hit the vagina, it might hit the toilet seat, and then it goes into a cup, right? And then we're going to use a machine, and we're going to take one of these strips, dip it in the urine, and then essentially run it through a machine that looks at all those colors there in the middle. And each one of those little colors signifies something. Blood in the urine, inflammation, what we call white blood cells, maybe bacteria, protein, different types of things that tell us this person might have an infection. But if it hit your labia or it hit the vagina, as it almost does in every single woman, that can be confusing because you're getting cells from the vagina into the cup, right? So it's not perfect. So when somebody tells you, oh, you have a UTI, as soon as you go into their office, they don't really know. They're guessing, okay? They're guessing and making an educated guess based on that strip. Is everybody with me so far? Okay. So then, what happens? Then we send your urine to a lab. And that little petri dish down there, we put your urine on a petri dish. We put the petri dish in an incubator. And it takes about 3 to 5 days to see if bacteria grows. So nobody knows when you're in the office if you actually have bacteria in your urine. They won't know that for 3 or 5 days until it grows. So then that middle picture, you can see that's bacteria on the slide. So 3 to 5 days later, we can say, yes, there was an infection, or no, there wasn't. Now, we may start you on an antibiotic if you're having symptoms, because we don't want you to be miserable for 3 to 5 days. But 3 to 5 days later, you should get a phone call from our office that says you had bacteria. And we tested your bacteria against antibiotics. So that's this last slide right here. Each one of those tiny circles is an antibiotic that we put on that petri dish to see if the antibiotic we gave you will work to kill the bacteria. So that, you can see the bacteria gets killed around those little circles. There's no bacteria there. That means that was the right antibiotic for you. So when you get that phone call that says you had an infection and we treated you with the right antibiotic, good. Or you had an infection and we gave you an antibiotic that's not going to work, we have to give you a different antibiotic. That's what's happening. Does that make sense? Okay. So, if that keeps happening, if you keep having bacterial infections in your urine, we're going to do a workup. And we might do an ultrasound of your kidneys to see if you have kidney stones or something else that could be causing infections. We might look inside your bladder with a tiny little camera in our office to see if there are findings of something that could be causing recurrent infections. Stones in your bladder, chronic infections. If you've had surgery before, sometimes some surgical products can be let in the bladder. And this picture down here in the right corner, see those things that look kind of like little cysts or chicken pox? That is a sign of chronic infections. And I see that a lot in my office for people who get urinary tract infections over and over again. And in patients like that, I might put you on a low-dose antibiotic for a longer period of time. I might even take you to the operating room to get rid of those little things. So that's some of what we do to work up recurrent infections. But the most important thing is, how do we prevent them? So there are 3 things in the clinical trials, so 3 things in the data that we have a lot of data to show prevent urinary tract infections. The first one is super easy. Well, I say it's easy. It can be hard, but it's cheap, and that's drinking water. If you drink 64 ounces of water a day, 2 liters of water a day, you will reduce your urinary tract infections by half in a year, 50%, just with water. So water is super, super important. We say it's the solution to pollution is dilution, okay? Dilute. So that's 1, that's water. 2 is estrogen cream. I'm about to talk a lot about estrogen cream, so I'm gonna save that one. But that is key. That is the best thing that you could do for many, many urologic problems. The third is cranberry. Now, people talk about cranberry. People tell me all the time that they drink their cranberry juice at home. I hate to tell you, but unless you like cranberry juice, you do not have to do that. There is no way you could drink enough cranberry juice to get the benefit. But cranberry pills, really good quality cranberry pills, are key. So there is an active ingredient in cranberry. It's called a PAC. That stands for proanthocyanidin, which you do not need to know or remember. But what it does is it prevents bacteria from sticking to the inside of the bladder, particularly E. coli bacteria. So some bacteria likes to stick to the bladder walls. This prevents it from doing that. So it is only effective if you have enough of the active ingredient, 36 milligrams of PACs. So you may find cranberry pills over the counter. There are plenty of good products out there. Sam's has one, Costco has one. This is my favorite, but no matter what, you have to look, here we go. You have to look for 36 milligrams of PACs. If it says that, it will help prevent urinary tract infections. If it doesn't say that, look for a product that has that. Okay, there are other things that we can do for urinary tract infections. I put these up there because you might be on these. Someone may have told you to take these. D-mannose is over the counter. That's this orange bottle at the bottom. That works well too. It also helps keep bacterial counts low. We just don't have as much data as we do on 1, 2, and 3. Same thing with a prescription drug called methenamine hippurate. Some of you may be on that. That's great. That keeps bacterial counts really low in the bladder. But again, we just don't have enough data on those two. We have a ton on the top 3. Okay, so my summary. Whenever you feel like you have a urinary tract infection, always ask for a urine culture. Always go get it tested, because we don't really know if it's because of bacteria or not until we check. Okay, it might be something totally different that we can fix and that you don't need antibiotics for. Number 2, water, water, water. Drink your water. I know it's hard to do. I tell people to get a big, like this, get one of these, and try to drink 2 of them, 1 of them by noon, and then 1 the rest of the day. I know it's a lot, especially when you tell me that, okay, if I drink that much, I'm just gonna leak, but I can fix the leakage, okay? So we can fix it all. Okay, vaginal estrogen we're gonna talk about, and if somebody keeps giving you antibiotics all the time because they say you have an infection, ask to see a urologist, because there's probably a cause, and we can probably find the cause and stop it. Okay, I told you I was going to talk about vaginal estrogen. It's my favorite thing, so here we go. There is something called genitourinary syndrome of menopause. So when you go through menopause, your body changes. You all know that. Everything changes. Your hair changes, skin gets thinner, your vagina and your urethra and your bladder are not immune to that, okay? So this curve over here, this yellow curve, shows estrogen levels, okay? At birth, at puberty, when you're menstruating, perimenopause, when it goes like this, which explains all the mood swings, and then post-menopause. After menopause, your estrogen as a female goes to from about 50 to 500 to almost 0. Men have an estrogen of about 25. You have less estrogen than your male partners after menopause, okay? And that has a lot of implications. Vaginal dryness, urinary leakage, prolapse, infections, discomfort with sex, pain, urethral burning, bladder burning. So many problems that we have in our pelvic floor are because of a lack of estrogen. This is a graph that just shows vaginal dryness 1 year, 2 years, and 3 years after menopause. We're talking 3 years after menopause, and 50% of people say that they have vaginal dryness. And you can imagine that just keeps going up, right? So everybody has this. This is a picture. I know this is a sciencey picture, but I think it's really telling. So on the left is a picture of somebody who is after menopause who has thin vaginal tissue. And Debbie told me not to get up on stage because I'm pregnant, but I'm gonna do this real quick, Debbie. Okay, so this is thin tissue, right? After 8 to 12 weeks of vaginal estrogen, which we're gonna talk about, just a vaginal estrogen cream that you just put inside the vagina with your finger, it goes from being this thin to this thick. Okay, that's another picture. This thin to that thick in 8 to 12 weeks. That's like premenopausal. That's great. And it has a lot of benefits. So, when you lose your vaginal estrogen, 2 big things happen. Okay, the tissue gets very thin, like I said, so you don't have a natural barrier. So you can't protect yourself from bacteria like that cause urinary tract infections, yeast infections, those type of things, because the tissue is so thin and so dry. The second thing that happens is your vagina wants to be acidic, okay? That's what keeps normal bacteria in check. You have bacteria that likes to live there, and it likes an acidic environment. When you lose your estrogen, your vagina becomes basic. It no longer is acidic, it becomes alkaline. It allows bad bacteria to overgrow. And that's part of what causes infections. It's part of what causes yeast infections, bacterial vaginosis, lots of things. So you can restore a normal pH in your vagina by using estrogen cream 2 to 3 times a week. That's it, 2 to 3 times a week. So people always ask me, what I heard estrogen is going to cause cancer or strokes or heart attacks. And that is all because we did a really bad job with a study 25 years ago called the Women's Health Initiative. You don't have to raise your hand, but think, if anybody was on hormone replacement therapy, and 20 years ago, all your doctors took you off of hormone replacement therapy because they said it was going to cause cancer. So they were wrong, and we now know that. We've gone back to look at those studies, and we know that that is not true. In fact, estrogen protected against breast cancer in a big group of people, and it also protected against dementia, and it protected against osteoporosis. And so it's a very nuanced argument. Now, that is a whole complex thing I won't get into right now, but my point is that all the studies and the things that scared people about estrogen were about systemic estrogen, estrogen that increased your blood levels, estrogen pills particularly. The estrogen I'm talking about is transvaginal estrogen. It is just used in the vagina, and almost nothing gets absorbed into your bloodstream. A very, very small amount gets absorbed into the bloodstream. So it is incredibly safe. There have been multiple studies that it does not cause cancer, it does not cause heart attacks, strokes, or blood clots. Any of the things that we got scared about estrogen for before. So super safe. It's about $20 to $30 for a tube of estrogen cream that will last you about 3 to 4 months. And the way I tell people to use it is to put a stripe of cream on the tip of their finger, like you're brushing your teeth, put it up in the vagina to about the second knuckle and rub it into the tissue, okay? It comes with an applicator, you don't need it, you can throw it away. Just your finger, 2 to 3 times a week, depending on if you have a uterus, okay? That will prevent urinary tract infections, but it does take about 8 to 12 weeks to work. So you might still get urinary tract infections in that time period. You might still have some dryness, but over that time period, it should significantly reduce that. I'm going to go through some of these slides. This is just to show that if you hate the cream, we have other options besides the cream. Okay, so far we've talked about urinary tract infections and genitourinary syndrome of menopause, which is also kind of vaginal dryness and some of the symptoms associated with it, and how water and estrogen cream and maybe some cranberry pills can go a long, long way to help prevent those things. So we're going to talk about leakage. Okay, so what is urinary leakage, or urinary incontinence is the technical term that we use, and that is the involuntary loss of urine from your body. So the way that your bladder should work is that your kidneys make urine, and then they drain urine through these tubes called ureters. You have 2 of them, and they go down into the bladder, they fill up your bladder, and once you're full, your pelvic floor should relax, your bladder should squeeze, and you should empty. So it requires coordination of the brain and spinal cord to give you permission, the bladder, and your sphincter, your pelvic floor. So here, bladder fills the kidney, the bladder gets full, your brain should say, okay, we're full, but we're not at a bathroom yet, so we're gonna just hold on and pump the brakes, let's not pee yet. Until you have time to get your pants down, you sit down, and then your pelvic floor should relax, your bladder should squeeze, and you should be able to empty everything out. That is how it should work perfectly. If you come to my office, you will see this poster that I made on every single door. There are 2 types of leakage. And not everyone knows that, and they're hard sometimes to differentiate between. So we're going to talk about 2 different types of leakage. because they are totally different and they happen for totally different reasons, and we fix them in totally different ways. So if you can start thinking about these things and what type of leakage do I have, then we're going to be a couple steps ahead, okay? So on the left, and we're going to go into this in a whole lot more detail, but this is, I'm going to say it multiple times. So there is one type of leakage called stress incontinence. That's leakage with coughing, sneezing, laughing, jumping, okay? You're putting stress on your pelvic floor, and that pressure, your pelvic floor is too weak to support it, and that causes leakage. So oftentimes this is after people have delivered babies or pushed something through the vaginal canal. The tissue is weaker, so your urethra, your urine tube, moves too much. It doesn't have the support that it needs. So when you do these heavy lifting or these exercises, your pelvic floor is not strong enough to keep the urine in. That's a sphincter pelvic floor strength problem. The other type of leakage is called urge incontinence. That is when it's urgency. Gotta go right now. Where's the bathroom? Mapping bathrooms, frequency, urgency, waking up at night to pee, because your bladder is a muscle and it's squeezing when it shouldn't squeeze. It's contracting when it shouldn't contract. That is a bladder spasm problem. Totally different than a pelvic floor weakness problem. So we have to know what we're treating so we can treat it effectively. So this is just another slide that basically says what I said before. 1 in 3 women has stress incontinence, coughing, sneezing, laughing, leakage. 1 in 4 women has overactive bladder. Most people have both, and we call that mixed incontinence. If you say, I leak all the time, I leak with both of those things, most people do. But normally, one of them is more bothersome than the other. Like most of my patients have had some type of coughing, sneezing, laughing leakage since they delivered a baby, but that was 25 years ago. And now they're in my office today because they wake up 5 times at night to pee. Or now they're wearing diapers or Depends or pads because they can't make it to the bathroom, and it's affecting their quality of life. So oftentimes there are both problems. That's most common. Of note, men can have these problems too, for different reasons. But men definitely have these problems, and 1 in 6 people has overactive bladder. That includes men and women. Okay, so I hear all the time, oh, I think it's normal. It's just normal, part of aging. It's not normal. It's common, but it's not normal. It's not how your bladder should function. It's not how your pelvic floor should function. It's just common. So we've normalized it. We've said, everybody's got it, it must be normal, but it's not. Okay, here's a slide that says it dramatically affects your quality of life. It can prevent people from doing things that they want to do, having relationships, attending functions. If you're worried about leaking or finding a bathroom, that can be pretty detrimental. And like I mentioned before, several things cause this. We do notice that it worsens with age. That's really a muscle tone and weakness problem. But if you have family members that have this, that could be part of it. Sometimes lifestyle modifications or behavioral things, like if you wait too long to get to the bathroom because you're distracted, those things can affect it. Coughing or COPD or emphysema puts a whole lot of pressure on your pelvic floor. Weight gain puts a lot of pressure on your pelvic floor. In fact, if you lose 5% of your body weight, you can improve your leakage by 50%. So some weight loss will also help take pressure off your pelvic floor. So how do we diagnose this? Mostly just listening. So if you come in, I'm going to ask you all these questions. When do you leak? How many times do you wake up at night? How many pads are you wearing? What do you drink during the day? Do you drink caffeine? Do you drink alcohol? Do you eat a lot of spicy foods? All these things can affect it. So mostly it's history taking. I will also do a pelvic exam, and I'm looking for a lot of different things. Vaginal thinning, your pelvic floor being weak, how strong it is. If you have some of these other things we're going to talk about during the lecture, because all of those things make a difference in what treatment options I might offer you. we also want to make sure you can empty your bladder. So something I didn't mention, but that's important, is that there is a small number of patients that don't empty their bladder well. So when you leak, it's actually overflow leakage. Your bladder's so full and it's not emptying that it's kind of like a cup runs over and you leak because you're not emptying. So there are simple tests we can do in the office where we put a little ultrasound probe on your bladder and we make sure that your bladder's empty. Very simple, painless, and that gives me a lot of information too. Okay, what can we do to fix this problem? So a lot of you may be looking at me saying, I don't want a surgery, because I'm a surgeon, I'm a urologic surgeon, but I do not operate on everybody, and there are many, many non-surgical options. So we're gonna start talking about those things. So sometimes lifestyle changes, right? Maybe some fitness, maybe some pelvic floor strengthening. You may have heard of Kegel exercises, where I tell people, pretend like you're putting an egg in your vagina and you're trying to crack it. That's using the right muscles, okay? Squeeze and lift. So those things can be helpful for stress incontinence, for this particular type of leakage, because what we're trying to do, remember, is strengthen the muscles that used to be strong, that have gotten weak. So if you can strengthen those muscles, re-strengthen those muscles on your own, or with a pelvic floor physical therapist, we could be halfway there, okay? That can help a ton. Here are some other non-surgical options that many people don't know about. So there are things called pessaries. We're gonna get into that in a little bit later, but these are basically little silicone inserts that go into the vagina that can lift or push on things in the way we want them to. So this little device down here called Revive gets inserted with almost like a tampon applicator, gets inserted into the vagina, and that little lip pushes up against the urethra so that when you cough and push down, that your urethra doesn't move, you don't leak. So these are over the counter. You can get these at H-E-B or Walmart or the drugstore and dramatically decrease your leakage with just something over the counter. So we have these options, and we can show you how to put them in and how to use them. The second option kind of does look like a tampon. It's one up in the corner, but it has a waist. It does the same thing. So it's a disposable version, but basically goes inside, pushes up against the tissue, and then it gets removed when you're done with it. Now, many of you may be looking at me like, I don't want to put anything up there right now, and that's fine. Let me tell you about more options. The standard of care, so what we used to do all the time for leakage was a surgery to tighten the tissue around the urethra. Some of you may have had it. It's called a Birch procedure. And then we moved away from that because it didn't work quite as well, to something called slings. Some of you may have had slings, or somebody may have told you they did a bladder tack or a bladder lift. If they did that, what they were doing was using either mesh or your own tissue or tissue from a cadaver to put a hammock underneath the urethra. And that little hammock it reconstructs or replaces the support underneath the urethra. I brought one of those. We're gonna talk about that in a second. I'm gonna just pass it. I'll start with you, Mary, and we'll just pass it back and forth. The way that this works is that the urethra goes on top. A little incision is made in the vagina underneath it. And so when you cough and sneeze, there's a hammock underneath it to prevent your urethra from moving and prevent you from leaking. It basically replaces the sphincter that's too weak, okay? This is the sling that I use, and so you all can feel it, but I'm gonna tell you about one other thing that's not a sling that works too. Okay. During COVID, during 2020, there's a product that became FDA approved in the United States. And nobody really heard about it because it was during COVID and nobody was doing elective surgery. And as you all remember, healthcare was kind of shut down. So I'm going to tell you about this because this is great. It's called Bulkamid. Bulkamid is a water-based gel. It has been used in Europe for over 7 years. It is safe enough that they are using it in children for certain indications in Europe. It is that safe. It's 97.5% water. And we used to use things like this. I'm going to come through here. We used to use things like this called bulking agents, which is kind of like a filler. So if you can imagine these celebrities who put like filler in their lips and fillers in their cheek, think about that in the urethra, okay? But instead of being plastic or silicone, this is mostly water. We used to use products like this, but they were a different type of product that actually worked by causing inflammation, and they only lasted for about 6 months or so. This product, which we now know about for over 7 years, still works in people with a 91% satisfaction rate after 7 years, okay? So the way that this works is we go to the surgery center, you get a very light anesthetic, like a twilight anesthesia. I could even probably do this without anesthesia if you didn't want it. But a twilight anesthesia like a colonoscopy. And it takes me about 5 minutes. I take a little camera, I go inside the bladder, the urethra with the camera, and I inject water pillows. Water pillows in 4 spots around the urethra that bulk. They just make it harder for urine to come out. It has no inflammatory response. There are no allergic reactions because it's mostly water. It is very little risk. The biggest risks are 2. One is that I put too much gel and it's harder for you to pee right afterwards. And I make sure everybody can pee before they leave. So if you couldn't pee, I would take a tiny little catheter, put it in and out, and that gel is super soft for a month. So it just moves out of the way. And then almost everybody can pee. So that's the biggest risk. The other is that I didn't put enough gel and it didn't work. And we have to go back and put more gel. And there's a chance of that. Over the 7-year time period, about 30 to 40% of people went back to get more gel. And most of those people were already much more dry, but they wanted to be perfect, right? They wanted to be better. So this is a minimally invasive alternative to a bigger surgery. I would call it a procedure. And in fact, if I had the equipment in my office, I would do it in my office. But we do it in the surgery center, and it also is a little bit more comfortable. But it's very effective. That's my little camera. My camera is about this long. That's what goes inside. And this just shows the cure rates and the satisfaction. Highly, highly satisfactory and very low risk. So that's another option, okay? And then finally, we get to the sling. So the sling is what we're passing around now. Like I mentioned before, there are several options. We'll go ahead and talk about mesh now because I'm sure that most people, when I say mesh and you feel this mesh, you're thinking mesh is bad. There were a lot of lawsuits about mesh. And you're right, there were. There were a lot of lawsuits about a bad mesh. So we used to use a mesh that was thick, almost kind of like cardboard, and not very porous, okay? So think about a really thick, kind of hard piece of plastic. That's what used to be used for mesh. And the body's immune system couldn't get into the crevices of that mesh, so it thought that's a foreign body, and it tried to spit it out. So that was a lot of the mesh complications were because the mesh was a different type of mesh. It was heavier, it was thicker, and it wasn't very porous. You'll see when I pass around these mesh, I have another piece to show you, you'll see the difference. We now use the same type of mesh in any repair in the body where we use mesh. So some of you may have had hernias or have friends who had hernia repairs with mesh. This is the same type of mesh as that. So the pores are a whole lot bigger. There are holes in it. It's very soft, it's very flexible, and that piece of mesh has less than a 5% risk of causing a problem. So it's much safer than it used to be. The other mesh I'm going to show you has less than a 1% risk of causing a problem. So the meshes we use now, the approval process was very stringent to be able to continue to use mesh. So we only use very, very safe mesh. Now, is there risk with any foreign body that you put in your body? Sure. And everybody reacts differently. But that is an option, and I want to encourage you to not be so scared of using the mesh that we use on the market, because all the bad mesh you can't use. They don't make it, you can't even find it. In fact, it was taken off the market before I even started practicing. So we couldn't even find it now. So that's the mesh story. In addition to mesh for a sling, I can use cadaver tissue that's safe and been processed. I can use your own tissue from your belly, or I can take it from your leg, and I can make other types of slings out of that tissue. So there are almost infinite options for how to get you dry if that is your goal. But we also have non-invasive options, so I want you to be aware of those. Okay, so we just talked about coughing, sneezing, laughing, leakage, okay? That's the stress incontinence, right? That's the weak pelvic floor. We're gonna pivot and we're gonna talk about overactive bladder. So some of you may have received a sheet when you walked in. If not, we have some more. This is the pathway for overactive bladder, okay? This is based on the guidelines from my governing body that's called the American Urologic Association. So we're gonna walk through this. So to switch gears and remind you where we are now, we're talking about overactive bladder and urge leakage. So gotta go right now. Urgency, frequency, rushing to get to the bathroom, waking up at night to pee, mapping bathrooms because you're always afraid you're not going to be able to find one. That's this type of leakage. And I mentioned earlier, 1 in 6 people has this problem. And no, it's not normal. So what is normal? How often should you be going to the bathroom? About every 2 to 4 hours, okay, depending on how much water you drink. You should comfortably be able to hold your bladder for at least 2 hours. If it's more frequently than that, that's frequency. At night, sometimes waking up once at night is normal, especially if you have liquid before bedtime. But more than that generally is not normal. And again, importantly, even if you have to go often, you should be able to hold it till you get there. Okay, we went through this already, so I'm going to skip through some of this here. Okay. So, what can we do for overactive bladder? So this is where I want y'all to look at your sheet. So you'll see at the top, it says urgency, frequency, urinary leakage, or urge incontinence. That first row that you're looking at is kind of our first step, okay? So we can work with a physical therapist, a pelvic floor physical therapist, that will work on relaxing your pelvic floor. So previously I told you about Kegels. Kegels are strengthening, right? You're trying to tighten, tighten, tighten. You actually want to do the opposite if you have this problem. We call it urge suppression. So when you feel that urge to go, we want you to take a deep breath and try to wiggle your toes and relax your pelvic floor and relax your body to allow your bladder to stop spasming. Okay, so it's a little bit different. And that's why working with a physical therapist is really helpful, is because they can specifically come up with a program for you, because it's hard to know exactly how to get your pelvic floor to do what you want it to do. The next thing you'll see there is dietary and behavioral modifications. So let's talk about that. I mentioned this earlier, but dietary and behavioral modifications can be things like stopping your fluid intake 2 hours before you go to bed so that you can pee everything out, okay? It can also be things like avoiding caffeine, alcohol, spicy foods, acidic foods. Tomato-based products are really acidic, for example. Acidic foods, artificial sugar, and sugar. Those are other things that irritate the bladder. So you may notice, and they don't affect everyone, and I'm certainly not taking away your cup of coffee if it doesn't cause a problem. But for my people who drink a pot of coffee a day and they're always running to the bathroom, try cutting back on that, or switching to half calf, or switching to decaf and seeing if it makes a difference, right? Or switching to tea, which is less acidic. Those little things might make a big difference for you. And then the last thing on that top row is medication. So there are 2 different types of medication for overactive bladder. And some of you may have been on these. The first one you'll see is an antimuscarinic or an anticholinergic medication. I'm going to rattle off some names, and they may sound familiar to you. Oxybutynin, Vesicare, Tolterodine, Detrol, Gelneek, Trospium. These are things that you may have tried before, you may be on now. They're medications that are older. They've been used for a very long time, and they can have side effects of dry eyes, dry mouth, and constipation. So the reason that we use those drugs is because they have a receptor on the bladder muscle, and those drugs bind to that receptor on the bladder muscle and cause the bladder to relax. But those receptors are in your mouth and in your eye and in your bowel, and some of them cross the brain. So that's why you get the side effects, is because it's not specific to just your bladder. Now, the biggest issue with those drugs is that they're on a list called the Beers list. The Beers list probably has a lot of medications that you might be on it, and all of them have been associated with dementia and cognitive dysfunction. So in my clinic, if you're over the age of 70, I generally don't even offer you those medicines because I don't want to make those problems worse. Now, they're cheaper, and insurance likes them better, and so sometimes we have to put you on them for a little while until we can move you on or prove to insurance that it's not a good idea. But for the most part, insurance knows it's not a good idea, and they don't make me use them anymore. So that's the first class of medicines. The other class, which you see below that, beta-3 agonists. Beta-3 agonists are a totally different type of medicine. And they also bind to a receptor on the bladder muscle, but that receptor is pretty much just on the bladder. So it doesn't have all the other side effects. It does not cause constipation or dry eye or dry mouth. Now, everybody reacts to medicine differently, so sure, I have patients tell me that they don't like that drug, but for the most part, no side effects and no drug interactions. And one of them just became generic a couple months ago, so it's getting much, much cheaper. The names of these 2 drugs are Mirbetriq and Gemtesa. So you don't have to know those names. You could take this to any doctor and say, I want one of these medicines, and they should know what you're talking about. But they can be more expensive. That's the caveat. They may be more expensive than the other drugs. And it's our job to help prove to insurance that you need these, that they're safer for you. Now, a lot of people stop their medicines after a year, 72%. Most of that is because of side effects. But there are also people that don't want to be on medicines. You take a lot of medicines. You don't want to be on more medicines. So we have other options. We have 3 options, and you'll see these at the bottom of the page. The first option is called tibial nerve stimulation. So think of it like acupuncture. You come into the office, we put a tiny little baby needle and a nerve over your ankle, and that signal goes back up to the bladder, or to the nerve to the bladder, and then stimulates the nerve to the bladder to calm down. It's 30 minutes a week for 12 weeks in a row. It's a lot of office visits, but you're just hanging out for 30 minutes with this little stimulation. And it takes about 4 to 6 weeks to notice a benefit. So it's not instantaneous. You have to be patient with it. It works about 60 to 70% of the time. So it's a good option. It's a non-invasive option. It's not my favorite option because it doesn't have as much success, but it's a really good alternative. So that's the left. In the middle is Botox. Botox, you may have heard of. People put it in their face for wrinkles. They put it in their heads for migraines. We put it in different muscle groups for spasms. It paralyzes muscles. That's how it works. So our goal here is to paralyze some of your bladder muscle so that it doesn't squeeze when it's not supposed to. Now, not the whole thing, but just some of the muscle fibers. So this procedure is done in my office for most people. You come into the office, we put a little bit of lidocaine in your bladder and we let it numb up for about 15 minutes. Bless you. And then I go inside with a tiny little camera and even tiny baby needle that you can't feel because you're numb, and I inject Botox into the bladder in 10 spots. It takes me about 45 seconds to a minute to do it, and it lasts for 6 months at a time. So 6 months later, it's gonna start to wear off, and you're gonna come back, and we're gonna do it again. And like I said, the procedure, you numb for about 15 minutes, the procedure takes a couple minutes. The biggest risk with that procedure is that I over-relax your bladder. And in 7% of people, that happens, where they feel like the first couple weeks afterwards, it's a little harder to pee, and they have to bend over or push down to pee. Most of the time, that goes away within about 2 to 3 weeks, because Botox starts to wear off a little bit. Very, very rarely do I have to change my plan, and do we have to teach someone how to put a little catheter into empty. And I probably do this 2 to 3 times a day in my office, and probably have 2 patients a year that I have to teach how to do that. So it's very, very unusual, but it's a risk. And if you're somebody who doesn't totally empty their bladder well, I might tell you that's not a really good idea. The third option is a pacemaker for the bladder. This device is approved for 3 reasons. Fecal leakage or fecal urgency, so leaking stool, urinary leakage and leaking urine, and not completely emptying your bladder. So 3 different things. And the way that it works is that we're testing a nerve. We put a wire on a nerve that goes down to the nerve to the bladder in the bowel, and we stimulate it. And we do this in the office. We test it in the office by putting 2 little wires down next to the nerve through your back with some numbing medicine. We do that for 5 days, and we test it for 5 days. And if it works, I take you to the surgery center, and also with a very light anesthetic, you could talk to me while I was doing it. I implant this in the fat over your butt, and it's like a little pacemaker battery, and it lasts for 15 years. So it works 94% of the time for fecal leakage, 85% of the time for bladder leakage, and a little less to try to get your bladder to empty, more like 50% for that problem. But this might be a good option, and we test it out before we put it in, so we know if it's gonna work before we put it in. Cindy and I, Cindy's my nurse practitioner, I showed you a picture of. Cindy does the test in the office, and I implant these. And we've done so many that we're now a center of excellence for these. So this is another good option to think about. Okay, we reached our last topic with, I think, 5 minutes to spare. Okay, last topic I want to tell you about is prolapse. And I'm going to give you a big overview of prolapse, because prolapse is very nuanced and can be very complicated, and it's very individualized, because every pelvic floor is different. But I'm going to tell you what it is and give you an overview of some treatment options, and then we'll have time for some questions. Okay, so what is prolapse? How many of you know what a hernia is? Everyone's kind of familiar with that? So hernia is weakness in tissue, okay? So if I have a hernia in my belly button, it's because there's weak tissue there, and whatever sits behind it can push through it. That's a hernia. The same thing can happen in your pelvic floor. Your pelvic floor is a bucket of muscles and ligaments. And with age or heavy lifting or having babies, even having babies and not even having them vaginally, something sitting on your pelvic floor causes everything to stretch out. And if everything stretches out, what sits on top of it falls into that space, okay? And because we're standing a lot, gravity is not our friend, and everything falls down. So that's what prolapse is it's the organs up here falling down through whatever's there, which happens to be our vaginas. That's prolapse. So up to 50% of women will have prolapse. Now, not everybody will be bothered by it. Many people have it and don't feel it at all. And if it doesn't cause a problem, it doesn't matter. You don't have to do a thing about it. But if it's bothering you, we can fix it. And we have to fix it in about 10% or 1 in 10 women. So what are some symptoms of prolapse? Vaginal bulge, feeling tissue down there when you're cleaning yourself, not being able to empty your bladder or your bowels, really bad constipation, those types of things. Pulling, so feeling some lower pelvic pain and pressure. And why does it happen? We talked about that already, lots of different reasons. So we're going to go through some of these pictures, and I'm going to try to explain to you what is kind of a complex thing to wrap your head around. So, like I mentioned, whatever organs sit in the pelvic floor can fall if there's not support there, right? So if it's your bladder falling, we call that a cystocele, but basically a prolapsed bladder. That means when we look inside that the bladder, the wall of your vagina that supports your bladder is weak. And so your bladder can fall into that, and it can make you not empty your bladder, and it can cause urinary tract infections because you can't empty your bladder. So when you come to my office with urinary tract infections, I'm going to do a pelvic exam because I'm looking for that. I want to know if that's why. A rectocele is the opposite, okay? Sorry, Debbie. Okay. Bladder, urethra. So this is like I cut me this way, and you're looking at my insides. Bladder, urethra, vagina, uterus, rectum. Okay? So here the bladder was falling into the vagina. Here, the rectum is falling into the vagina. So people who feel like they have stool trapping, or they have to put their fingers in to push back to have a bowel movement, it's oftentimes because of that tissue right there. These people have small intestines that are coming through into the pelvic floor. What if you don't have your uterus anymore? This is a patient who's had a hysterectomy, no uterus, and it's just the top part of the vagina that's falling. And finally, if you do have your uterus and there's no support, your uterus can fall. And there are a lot of different stages of this. They are not all this bad. I'm showing you bad pictures. It may just be a little bit. And like I said, it may not make a difference at all. But if it's bothering you, if you're having trouble emptying your bladder or your bowel, or you have something you have to constantly push back up, we have lots of options for you. So, one of those options is a pessary. I mentioned that before. A pessary is like a little silicone donut, kind of like a diaphragm, if you remember what those were. And this gets inserted, and it can be removed and replaced. And you can remove it and replace it, and I can show you how and teach you how. Or we can do that in my office every 3 months. I like for people to remove them every day, but if you can't, you can keep it in for a couple weeks at a time. Or if you don't have the dexterity to do it yourself, you just come to my office every 3 months, we take it out, we wash it, we put it back in, and we make sure everything looks healthy. This is a non-surgical option to push everything back up, okay? We also have surgical options. So I can, with a lot of different tools in my tool chest, lift your bladder, push back the rectum, push up the uterus. I can do it through the vagina. I can close the vagina if you're not sexually active. I can use a mesh to support the vagina. And this is done with a robotic surgery through 5 little tiny incisions in your belly, where I use a mesh and I put it on the front and the back wall of the vagina, and I lift everything up. Less than 1% risk of a mesh complication, works for 95% of people, and after 15 years, they still don't have prolapse in 95% of people. That's this mesh. So I'm gonna let you feel this one too, because this one's soft and squishy. So you can feel it and you can stretch it. Yes, ma'am. That is called a sacrocolpopexy. So, sacrocolpopexy. Sacro means your sacrum, which is where I sew it to, and colpo means cervix, or where your cervix used to be. And so I'm putting a piece of mesh around the vagina and lifting everything back up, okay? Most of the time, I send patients home the same day after the surgery. This is the most involved surgery I do, and most patients go home the same day. Sometimes we keep you overnight. And for all the other surgeries I mentioned, they're all outpatient surgeries that take me about an hour to an hour and a half. So if surgery is something you're interested in, we certainly can do that, and you're not going to be down for weeks. Most people, if I go through the vagina, have very minimal pain. Most people with this are up and walking the same day, and then you feel a little bloated for a couple weeks, but most of my patients within about 2 weeks feel like themselves. So, we're wrapping up here. This is just to show you the robots, which are the minimally invasive robotic tools that I use to be able to do that surgery through 5 tiny little incisions. So we talked about this already. So recovery, right. So I just don't want you doing any heavy lifting after a surgery like this because we want everything to heal in place. But generally, recovery can be pretty quick. Okay, that was a lot of information about a lot of different topics. So I'm gonna allow, Debbie, do you have, or Kathy, do you have the microphone? We're gonna allow some time for questions. And again, I gave you a lot of information, but what I really want you to take away is that we have a lot of options for all of these problems. And I just want you to feel comfortable asking about them, because no matter where you are and the treatments that you've tried or how aggressive you want to be, we have non-invasive and more invasive options. So we can get you much better with not much burden. And I want you to have confidence in that when you come in. And if you're seeing someone who isn't offering you these things, not every one of my partners does these surgeries, right? We all have specialty, we all specialize in certain things. So just ask for one of my partners who does procedures on the pelvic floor or who treats women, because we'll be able to offer you all of these options, and I don't want you to feel like you don't have access to these. Does that make sense? Okay, great. Okay, I'll take some questions.
On the medication, how long approximately does it take for the beta-3 agonist medication to start making a difference?
Great question. Normally about 2 weeks. So the other medications work a little faster. The beta-3 agonists take about 2 weeks. In general, we keep you on them for 4 weeks and then reassess your symptoms.
In the hospital, they use perineal suction devices
Yeah.
to manage overnight leakage, so they don't have to come take you to the bathroom every 30 minutes.
Yes.
Do those promote urinary infection?
They do not. They don't promote urinary infection. So she's talking about something called a PureWick, and I'm so glad that you brought that up because I forgot to include that. A PureWick is an external suction device that sits outside the labia and so it allows you to basically leak, and then it sucks the urine into a suction canister. And they are available at home. Medicare does not, as far as I know, Medicare won't cover them at home, so they can be a little bit pricey, but we can order them through a home health service, and it will allow you to basically stay dry. Now, they don't promote urinary tract infections. My biggest issue is that there are people who put one of those devices on patients without trying to figure out what's actually going on. So if you're one of those people whose bladder is really, really full in the hospital and the nurse puts one on because without thinking, is she actually emptying her bladder? Then there are people who have a really full bladder who need it to be emptied in a different way because it won't suck the urine out of the bladder. It just sucks up what comes out. Does that make sense? So if the bladder's full, you might have a urinary tract infection because your bladder's full and you're not emptying it. That's not on the PureWick, that's just your bladder. But that's on us to know the difference. That's my thought on those things.
This is going to be a dumb question, I'm afraid.
No such thing.
If you cannot drink 64 ounces of water a day, how do you feel about Gatorade?
So Gatorade has a couple things. It depends on the issue, right? If you can't drink that much and your doctor's telling you you need electrolytes and you need salt and you need sugar and you need other things, and that is perfectly appropriate. Like your cardiologist and your nephrologist trump me, right? They get to, that's more important. But Gatorade can have dyes, artificial sugar, and it has irritants in it that can make the bladder spasm more. So if you're asking me, is it bad for overactive bladder? Potentially. Is it going to help with urinary tract infections? Volume, like I said, dilution is good. And so if another doctor says you need electrolyte water, drink Gatorade, that will certainly help. Even if you can dilute it with some water, that will be helpful.
Thank you.
I have a question on cystitis.
Yeah.
You covered UTIs, but you didn't say anything about cystitis, and that's an issue. You covered UTIs, but you didn't cover anything on cystitis, and I think that's an issue for a lot of women who go to their doctor thinking they have a UTI. Did you cover that?
Yes, for sure. Thank you for asking. So cystitis means inflammation of the bladder. Okay, so you can have cystitis for bacterial reasons. That's a UTI, so that's bacterial cystitis. And what Anne is asking is about what about cystitis that is not from a urinary tract infection, right? And so there is a diagnosis called interstitial cystitis. There are also other types of cystitis like radiation cystitis. So if you had radiation in your pelvis for some type of cancer, it can cause your bladder to be painful and bleed and be irritated. If we can't find a reason, like there's no bacteria, it's not overactive bladder, there's not some other reason for it, then there is a diagnosis where we say, we don't know why you're having this pain, but you're having this pain. And that's probably an hour lecture in and of itself, but that is, there are multiple, in fact, 6 different pathways to try to figure out and treat why people have bladder pain that aren't having infections. A large part of those people, it's genitourinary syndrome of menopause. It's because of menopause, and so estrogen actually helps fix that problem. But it's complex because there can be a lot of reasons why people might have bladder pain and discomfort without having a reason for it. And sometimes it's your nerves, sometimes it's nerve pain. And I have 4 medicines and 3 procedures and bladder installations and lots of things that I can try for that. But oftentimes it's trial and error, and everybody's a little different, and we have to work through that together. And I basically give you a piece of paper, and you take it home with you, and every time we try something that doesn't work, you cross it off and we try the next thing. It's a good question.
I had a question. Is this saying avoiding dairy?
Diary. Is it spelled wrong? Okay. Avoiding diary. So avoiding diary is helpful for people where we can't really figure out why is it that you're having leakage, right? Or what's going on exactly. Because like I said, a lot of people have both types of leakage, or they leak all the time, or they leak and they don't even know when they're leaking, right? You check your pad and it's wet and you don't know why. So keeping a diary of what you're eating and drinking and the timing of your leakage, and if you're waking up at night to pee, can help us sort those things out.
Well, thank you so much. And you've even gone overtime, so I really appreciate your patience and everything. And so thank you. We have, she has cards. I hope everybody got a card. If not, we can send them to them.
Yes, and on that card, on the back side, it has 2 locations for me. I no longer go to the 38th Street location, and in fact, in a month, all of our partners are moving to that new building, so we won't be at that location. So it's the Radham Lane location for me, but like I said, I have plenty of partners that are wonderful and will take very, very good care of you. So anyone at Urology Austin will take good care of you.
Thank you so much.
Thanks.
And I'm so glad you got here before. Thank you. evaluation forms. Thank you.